Hi guys, it's Dave here from London, Dave Pao. Um, Thanks Sarah for getting us all together. Really grateful to you for doing that. So, hi Sarah, Zachary, Dennis, both Rachels, Gilles. Very nice to meet you. I wanted to put together this presentation so that I could introduce myself and my research here at the RCA, and really so that we could kick off. It could kick off a conversation that we can have on at our Google Hangout on Friday, um, and I'm quite keen, really, for this panel discussion to be all of ours rather than dictated by me. So, if it's all right with you, I am going to kick off with a brief introduction to me, Dave's version of the history of medicine, and I think I'm going to try and focus on what I consider to be the main problem, one of the main problems I have with modern healthcare delivery, and how I see design as the way in which we can nudge medicine towards a kind of deeper, uh, broader evolution instead of a retrograde backward step to a narrow biomedical model. So I'm going to try and be succinct if I can. It's not so easy, but I'll give it my best shot. I'm a UK-born doctor, trained in general internal medicine, specialising in sexual health and HIV, so venereology, I guess. Most of the patients I look after are living with HIV, and I have a postgraduate research degree in the viral dynamics and the behavioural dynamics of HIV transmission. I last year started a PhD at the Royal College of Art, where I am pursuing a design PhD. I do now I do like 1 or 2 days clinical work a week. Dave's potted history of medicine tour. I maintain that medicine is rooted in the humanities. I like to think that medicine has been hijacked by science, and actually it is an art that uses science very wisely. I think when we hit the 17th century or so, reductionist medicine became so extremely successful that actually men did start to mistake medicine for magic. And even in my field, in HIV, I can say that the medication that we use, the antiretroviral medication, is nothing short of miraculous in terms of what it achieves. But this man-as-machine biomedical model separates disease from the problems of living, and to practice medicine, whether physician, nurse, psychologist, healthcare assistant, or indeed as a patient in that system, to separate disease from the problems of living means nothing but frustration and poor clinical outcomes, because the problems of living are so deeply contextualized into disease or with disease that we need a broader model. Of course, there is a broader model. Engel and others actually, with a biopsychosocial model, came along that kind of helped us look at health in a broader way. But my argument is that modern healthcare does all it can to push medicine back towards a biomedical narrow model. And this is one of my favourite graphics from the NHS, the British NHS. It purports to represent the wonders of modern medicine. I think it represents two of its major problems. The first is fragmentation, so a patient sees multiple clinicians, all who have a restricted plane of focus which seldom overlap. And secondly, we have this idea that healthcare has been digitized, so electronic medical records are rife, but actually they've had zero design input. So actually they'd measure quantitative data very well, blood pressure, lab results, height, weight, but they are almost unable to record with any nuance context, narrative, beliefs, emotions, all the things that are really important to self-care. On a even slightly more sinister level, I would say that these electronic patient records record what's important not to the patient and not to the doctor, but they record what's important to the financial managers and to the politicians. So this is my favourite quote from this year from Glyn Elwyn. And so if anything, my mission for my PhD is that we as doctors and healthcare providers should be given tools which facilitate our ability to have a conversation. So we're not sitting there firing code at patients and expecting them to come back at us with code, because they don't speak code, they speak conversational language. And so metaphorically, in a sense, in my consultations, I want to be able to put myself in the patient's shoes and see their perspective before coming back to my shoes and my perspective, such that I can offer them myself as a professional, which is why they've come to see me. And if I don't see their perspective, I don't feel that I'm doing a proper job. And we have 10 minutes now, or 12 minutes with each patient, and I think somewhere, somehow, we can use design to grab some time. Patients tend to be time rich, and drag it into the consultation so that we as physicians or clinicians understand our patients' story and context just a little bit better. So one of the things I learned at art school, I've learned more at art school about science than I have than I did at medical school. I've learned that science is a study of the natural world, that it works through experiment, through classification, through analysis, and that its characteristics are objectivity, neutrality, truth, and rationality. I think that this is kind of what medicine has been hijacked by, and I want to push back the boundaries so that medicine also includes the humanities. So the human experience through storytelling, analogy, metaphor, and so that we have these opposite characteristics to those of science. We have subjectivity and justice and commitment and some imagination. And one of the best things that I've learned at art school is that there is a third way, a third culture, or a third language, and that is design. And what excites me about design is that it is an artificial world, albeit, but it has the characteristics of value, ingenuity, empathy, and appropriateness. And that every single consulting room, certainly in the UK, has a digital screen that is internet connected and therefore is a portal into the world of design, such that we can facilitate the doctor-patient conversation. There are so many examples of the use of art and design in medicine where complex concepts have been described, represented, simplified, such that we can have conversations about issues between different people that get us to better clinical outcomes. And of course, it's not just the professional perspective. We also can look at patient perspective and see that actually using language other than verbal, we can represent not only external processes or an anatomical physicality, but even inner space. This is one of my favourite works from Orla O'Brien in Ireland, who got patients, or people rather, to mark on the human body where they felt different emotions. So I'd just like to wrap up by giving you or offering you my simplified model of medicine, of my ideal broad medicine, which isn't just mine. I am sure that there are many in the field of the medical humanities that will share this, but I like the way that it offers a glimpse into a broad medical model. This is the old biomedical man as machine model, where statistics and science come together and offer us hard fact and evidence-based medicine. I argue that actually if we just add on the humanities, the way in which human beings express their perspective, what we end up with is a different way of conversing. We hear, we see perspective, context, metaphor, narrative, meaning. And then the intersections between these three offer us, in my mind, a pretty good medical reality. So we immediately have the social sciences. So we have psychology, we have sociology, but they are not pseudo-objectified. They remain firmly rooted from the patient's perspective. So we are able to take into account not really the idea of patient-centered medicine, but relationship-centered medicine. So the relationship between the doctor and the patient is paramount. It offers us what we have today. So we have this, what I call order, this intersection between statistics and science, which is so critical to modern medicine. But it puts it in a place where it doesn't have sole dominion, where its dominance is reduced into a more reasonable context. And what I love about this model in particular is that we have a space for the unknown. I call it chaos only to polarize it against order, but in a way this is unknown. So there are so many things that we don't understand about well-being and health. There are so many there are so many areas. So even a good example would be emotional medicine or psychosomatic medicine, traditional Chinese medicine, acupuncture, Reiki, homeopathy, mindfulness, meditation, Tibetan medicine, quantum medicine. All of these things which medicine as biomedical medicine doesn't understand excludes. And so what you end up with biomedical, the biomedical model is a narrowing down by the exclusion of the unknown, such that actually you end up not with a model but with dogma. And so what I love about this humanities-based model is that all of those things that we don't understand or don't yet understand, we can hold and we can acknowledge and we can say, well, okay, let's just keep it there and let's see what comes of it. So this is the kind of model that I would like to promote with design. And my kind of opening, my starter to you really is, I'm sorry it's a bit open and a bit loose, but I'm kind of saying, well, what do we all feel we can contribute to a panel discussion around this model? I want to just end here with a really nice paper from 2011, which kind of gives me my evidence that medicine is in need of something. This was a video recording of senior doctors in Scandinavia. It's either, I think it might have been Finland, it might have been Norway, but anyway, a high caliber health system where they videoed senior consultations, and they discovered that of the 3 characteristics needed by a doctor, really doctors only fulfilled 2. They were courteous, shaking hands, being polite. They were knowledgeable, so they were techie, but what they were not was, or what they demonstrated was existential neglect. So here are the conclusions. Moral offence, existential concerns ignored. And this idea that there is a moral problem intrinsically bound to modern medical practice. So it's this area that I want to explore with design, which I am sure that somehow, some way, we can help everyday, mundane clinical conversations deepen and broaden health outcomes. Thanks very much for listening. I'm sorry I've rattled on for longer than I really wanted to, but I haven't really found a decent way of making this intro more succinct. So hopefully you've got time in your busy lives to look through this and listen to me burbling away. And I'm really looking forward to seeing you all or meeting you all at our Google Hangout on Friday. So goodbye from London. See you then.